Thank you, Mr. Chairman, for the kind introduction. Good afternoon, everyone. I will be talking on this topic of irreducible posterior sagging in chronic PCL laxity. Okay. Let's look at this case of 38-year-old lady who had alleged MVA 1 year prior to presentation. She sustained fracture right femur, fracture right tibia, fracture left humerus, all were fixed. She was referred to us for knee instability after a year when all the fractures were united. Clinically, there was no effusion, there was posterior sagging. PDT was grade 2 with irreducible step off. Case number 2, a 24-year-old student had alleged MVA 2 years prior, sustained head injury, fracture femur with popliteal artery injury, bypass graft was done. However, unfortunately, 3 weeks later, the vascular bypass graft was thrombosed and however, it was fortunate enough that she had good collaterals and the limb survived. She was referred only after a year with complaint of left knee instability. Clinically, there was no effusion. There was posterior sagging. PDT was of grade 3 with irreducible step off. The varus laxity of grade 2 was found, and she had a positive posterolateral drawer test indicative of a combined injury of PCL and PLC. So what do we do with such cases? We know that in both cases, PCL reconstruction would be needed to stabilize the knee. But two things that we need to ask ourselves before we decide. Is the normal tibio-femoral relationship correctable or not? If we were to do a PCL reconstruction, will it be able to restore the normal tibio-femoral relationship or not? So, in order to understand what really happened, let's see the structure involved in a little bit more detail. Sorry, the mouse it's not even working here. Okay, all right. So in the normal knee, the tibio-femoral relationship is evidenced by the fact that the tibia is in alignment to the femur in every aspect. Radiologically, the posterior border of the tibia should be level with the posterior margin of the femoral condyle. However, this varies from person to person, and that's why we need to check and compare with the contralateral normal knee. Anteriorly, the amount of the tibia that goes beyond the superior margin of anterobody of the femoral condyle actually is the step off that I was talking about, and this is the one that we should sensate during clinical examination. In supine position, when the knee is horizontal, we can expect effect of gravity onto the proximal tibia. So in an intact PCL knee, the knee remains in position. But when it is deficient, this gravity pulls the proximal tibia posteriorly. So following knee injury, you can imagine when the knee is swollen and the limb is heavy, and this force becomes much more prominent. So what does this mean? Following acute PCL injury, if appropriate treatment is instituted and normal tibio-femoral relationship is maintained until PCL heals, it can heal in appropriate position, appropriate length, and appropriate tension. So without appropriate treatment, however, the knee sags posteriorly, and if the step off is not maintained during healing process, so it can lead to PCL laxity. With insufficient anterior mobilization, usually we order this during physiotherapy, this can lead to fixed posterior subluxation or posterior sagging, hence the irreducible step off. So now, let's just ask ourselves, why does this really happen? How does this happen? So functionally, let's look at the capsule. It can be divided into thirds, the anterior third, middle, and the posterior third. So middle and the posterior third are the ones that forms the components of the tibiofemoral articulation. So let's focus here. So the ones that I write in red is actually the posterior capsule. It lies just behind the PCL fibers. So in theory, following PCL injury, this posterior capsule can be injured as well. And if during healing, the knee is not being maintained in good tibiofemoral relationship, So we can imagine what can happen when the posterior capsule heals. It can heal in shortened position, and I'll be talking about posterior capsule contracture here. So the medial step off refers to the amount of palpable medial tibial plateau that protrudes anteriorly in relation to the medial femoral condyle. So in most patients, this is about 1 centimeter, and in order to determine whether the step off is really normal or not, you have to compare with the contralateral knee. So if the step off is less than the other knee, it means that the knee is posteriorly subluxated. If it is reduced to normal with maximum anterior force, then we can say that it is reducible, and vice versa. So during posterior drawer test, we do grade our test, right? So it depends on the amount of posterior tibial translation, or it can be graded based on the position of plateau in relation to the femur. So if the medial step off is not restored during this maneuver, there is no zero position. So when there is no zero position, always have to be beware that there will be less amount of posterior tibial translation, and it just means that apparent translation is much less as compared to the actual translation. So fixed posterior subluxation, this is the terminology being described by Strobel and his co-authors in the techniques in orthopedics. He studied on 248 patients who had PCL deficiency, out of which 109 patients, which is 44% in the study population, had fixed posterior tibial subluxation. So his measurement was based on the anterior and posterior stress radiographs. So he reported that high failure rate was found following PCL reconstruction in such cases, and they recommended that this should be addressed before posterior cruciate ligament reconstruction to prevent overloading of the graft. So how do we treat such condition? The posterior capsular release is one of the treatment options that we can do for such patient, knowing the posterior capsule could be the culprit in such condition. So this involves sectioning the posterior capsule, either partially or completely, depending on the severity of the fixed posterior subluxation. The posteromedial capsule should be released first, as this is commonly the commonest culprit before considering to release the posterolateral capsule. So during arthroscopy, diagnostic arthroscopy is performed in the standard manner. So once intra-articular issues have been addressed, the scope is maneuvered to visualize the posteromedial compartment and establish the posteromedial portal, and I use RF ablator to use this probe to be introduced through the posteromedial portal and work from medial to the center towards the posterior septum to release the posteromedial capsule. So this is done away from the meniscocapsular junction, usually midpoint between that junction as well and the insertion of the capsule proximally. And knowing that in such conditions, the capsule can be really quite thick. So I would usually do it slowly, gradually, layer by layer, until complete release is done. And how do we know that it is complete? When the medial head of the gastrocnemius muscle and the tendon come into view, which appears as glistening of the structures behind there, then I know that the release is complete. So this is showing the ablator is used to release the posteromedial capsule from medial to lateral towards the posterior septum. The technique of the transseptal approach for PCL reconstruction actually is similar. So you can use this towards the transseptum, towards the posterior septum to release the posteromedial capsule and connect it to the posterolateral compartment as well. So you can see here the structure behind there. You can see the glistening structure of the medial head of gastroc tendon with its muscles at the back there. So it is sufficient to release that much. Once you have reached the posterior septum, you can actually use switching stick introduced through this posteromedial portal and park it there, and then switch the telescope to view the posterolateral compartment and establish the posterolateral portal. And similarly, the release of the posterolateral capsule starts from lateral towards the center, and eventually try to identify where the switching stick that had been introduced from the posteromedial portal is, then eventually work around it, and it's like connecting the dots, connecting the two compartments between the posteromedial compartment and the posterolateral compartment. Okay, it's almost done. So this is already at the posterior septum. So you can see the electoral head of gastroc head just now, glistening structure. And of course, in this region, it is very important, all the more reason to take extra caution, because the neurovascular bundle, as shown earlier by the first speaker, the location is actually not that far. It's very, very near. So this is the final part towards the septum. Towards the center here, in this particular case, I did not use any switching stick, but yes, as I mentioned, you can use the transseptal approach of PCL reconstruction similarly to identify where you are. So you are safe with regard to the sticking to the within the joint and not getting to the. Okay, so now, after completion of the release, one may consider reconstructing the PCL in one stage. However, one needs to know the disadvantages, among which are extravasation of fluid into the calf and compartment syndrome. So especially when dealing with a vascular injured limb, two-stage procedures is highly recommended. So risks and complications include neurovascular injuries. Studies have shown that the neurovascular is just behind there, and it's merely like 10 to 12 millimeters away from the posterior plateau. And extravasation of fluid, I had already mentioned just now, can lead to compartment syndrome. You can have hematoma. You can have recurrence of irreducible posterior sagging as well. So in the post-op period, the rehab part is very, very important to aim at maintaining the medial step off. So this includes the physiotherapy as well as the bracing, proper bracing. So how do we minimize? You need extra caution with the use of the ablator, good visualization of the capsule at all times. And always remember, this is the key. We are working at the darkest point, darkest part of the knee when you don't see, you don't do anything. And yes, speed does matter, but be safe is more important. So if combined with PCL reconstruction in single stage, this part has to wait until all the tunnels have been prepared. And release should be done just prior to the graft insertion. And the physiotherapist will be able to help us with anterior joint mobilization immediately post-op with the proper PCL knee bracing. So take-home message, irreducible posterior sagging is a condition of neglected PCL injured knee. Some of the names mentioned in the literature, fixed posterior tibial subluxation, fixed posterior sagging, irreducible medial step off, these all mean the same thing, and one must have high index of suspicion when dealing with neglected ones. Diagnosis can be made by comparing the medial step off of the contralateral knee. Anything less than 10 millimeters, you have to have high index of suspicion that it can be a posteriorly subluxated knee. And this needs to be addressed prior to PCL reconstruction. Arthroscopic posterior capsular release is a relatively safe treatment option and can be easily reproducible. With that, I thank you.